There's still some people filtering in. So. Alrighty. Welcome to the Saturday session of our Mental Health Matters Conference. It was an amazing night last night. And if you weren't here for last night's, we did record it, and we will post about where you can watch that because it was really, really excellent. This is the time where I ask you to take your cell phone out. Please put it on silence if you haven't already. All right. Thank you very much for that. All right, this morning will be formatted differently than last night. We'll be taking a short break at one point and having some refreshments and stuff. So we'll have a little break, bathroom break, whatever kind of break you need. But otherwise, we've got a whole lot of really important and useful, very practical information. Now, some of it may not be applicable to everyone, but just wait, because the next thing may be very applicable to you or your situation. So you'll be taking in a whole lot. If you need, there's going to be a whole lot of information given on slides. You can whip your phone out and take a picture of it. We give you leave to use your phone. All right, so let me introduce our speaker for this morning. Holly Lewis is a board-certified psychiatric mental health nurse practitioner. She works in Columbia, where she lives with her family. And she's probably in the mental health business because she's actually my sister. So, right, I twisted her arm into doing this for us. So, no, she has a passion for the topic of mental health. She loves Jesus and she loves people. And I don't think there are too many people that I know that have the deep compassion that she has. And so I'm really, really thrilled that she's giving her time to share with us today. All right, I think that is it. Actually, no, that's not it. You'll see there are note cards up here. It's up to you if you want to use these or not. We will have a question and answer time at the very end, so if something's coming to mind, you don't have to write it down on a card. I just have cards here because if you want to stay anonymous, that's totally fine. And you can just write out a question and stick it in these baskets, and we'll address that during the question and answer time. Otherwise, you'll have a chance to, stand up and shout a question at her later. So, all right, I think that is it. I'm going to pray, and then we'll get started. Dear God, we are thankful, so thankful that this group is here this morning. Thank you for Holly and her willingness to share with us. I pray that you give her peace and calm. Just give her the right focus and the right words that she needs to say to us this morning. I pray that you'd help us to take in everything that we need to, and that this information would be very useful and helpful in many different situations in our lives. And so, Lord, we're giving you this morning and trusting that you'll do something great with it. In your name, amen. All right.
All right, good morning. Get my stuff organized here. Okay, well, I am really thankful for the opportunity to speak with all of you. Thank you so much. And I just think it's really forward-thinking, very current thinking that this church is offering a seminar about mental health matters. I think it's really important that we as a faith community kind of bring some awareness about mental health issues and kind of take it out of the shadows and, talk about the hope that comes from knowing Christ and all of the treatment options that there are available, and just kind of taking away sort of the secrecy around mental health issues and acknowledging that this is, for many people, it's a clinical issue, no different than if somebody struggled with diabetes or blood pressure issues or anything else. So anyway, so I'm really thankful for the opportunity to come and share with you. Steph mentioned that there's going to be a lot of information provided. Some of this might seem a little dry and a little bit like you're sitting in a classroom. So bear with me on that. It's kind of a very crash course in mental health. And the first half of this seminar this morning is really going to be focused on kind of giving you as much information that I can give you on some of the more commonly diagnosed mental health conditions, the ones that we tend to struggle with more often than others, so it's not exhaustive by any means, but there's going to be a little information in here at some points that's kind of dry. I'll try to move through that more quickly. And then the second half is going to be really more focused on the practical tools and some things that we can implement at home, even just on our own, without even necessarily getting clinical guidance on those things. So we'll get started. The first slide is going to talk about statistics. So we'll look at that. We are not alone. If you struggle with any sort of feelings of anxiety or depression, the data on this is pretty convincing. We are absolutely not alone. So the number of adults aged 18 and older with feelings of worry, nervousness, or anxiety on a regular basis, 11.7%, and that's just what they captured in surveys. That is by no means a thorough number. I think the number for these statistics is actually much higher, but if you think about the US population being over 331 million people, 11.7 turns into about 39.8 million people, so that's a massive number. Again, the percent of adults aged 18 and over with feelings of depression on a regular basis, 4.8%, based off of statistics done in 2021 off the US population. That's over 16 million people. More than 1 in 5 women in the United States experienced a mental health condition like depression or anxiety. So if you look around, 1 in 5, that's probably more like 1 in 3. 1 in 4, if you think about people who will actually admit and talk about these feelings, that's a large number. Then the World Health Organization reported in 2021 that about 264 million people around the world, specifically young adults ages 18 to 25, are affected by depression. And this is a massive impact on economies, even around the world. That's over $1 trillion. Just in treatment costs, and then you got to factor in missed work, just all of the healthcare resources that go into that. So there's a massive impact that's experienced just because of depression, and that's not even counting the other diagnoses. So we are not alone. This is a major issue, and even if people around you aren't necessarily talking about it, you can bet that at your workplace, at your family gatherings, even in your church, there are people struggling. And I think that helps us remember too, when we have those interactions with people, like maybe at the store, you go to the bank, you go to the pharmacy, you're interacting with people in the public, and maybe somebody's being really grouchy or just unkind, or they just seem really upset, they have that resting angry face, maybe pause for a minute and think that they could be dealing with one of these issues. They could be having some incredible pain inside that they just haven't shared or been able to deal with. So it helps us kind of deal with others with some compassion and understanding. When you think about numbers like this is a major, major issue. So, all right, next slide, please. I wanted to pause for a minute here and just talk about using person-first language. In my field, this is extremely important. And this is one of the reasons, I think, why people keep their mental health issues in the shadows. There's a lot of stigmatization. There's a lot of language used that sort of casts a shadow or kind of casts a negative view of people that struggle with mental illness. So I just wanted to quickly go over this a little bit. Luke 6:31 tells us to follow the golden rule, do to others as you would have them do to you. If we wouldn't want to be called names, then we should be careful about the language that we use when we're talking about people who are struggling with a mental health disorder. It's easy to just casually throw terms around like, oh, that's nuts, that's crazy, oh, he's crazy. Those words can hurt. So if we're referring to somebody, and that's really where this matters, if we're talking about somebody who's behaving erratically, who's withdrawing from the family, who's isolating themselves, who's anxious and nervous all the time, having panic attacks, we don't want to talk about them with terms that are negative. That helps keep these things in the shadows. We really want to talk about somebody having a mental health disorder or struggling with a mental condition versus calling them names. Even throwing the word manic around, even though that seems, like pretty commonly word, manic Mondays, things like that, that word actually, for some people is very sensitive. People who struggle with with using substances. This is a substance use disorder versus calling somebody an addict or a drug abuser, a drug user, things like that. And I'm not saying we all have to be tiptoeing or that we have to constantly be, nervous about how we're talking. I think it's just important to kind of plant seeds of kindness in the way that we talk about these issues and the people that are struggling with them. I think the kinder that we are in our language and the more understanding that we are and using terms with sensitivity really opens the door for friends that might be struggling to talk to us. And it just demonstrates the kindness that Christ showed to others. We'll talk more about this issue a little later on in the session, but when we talk about somebody whose life ended because of suicide, we talk about them having died by suicide or being lost by suicide versus they committed suicide. We really want to talk about things kindly. Finally, we talk about things in terms of what's normal, what's not normal. I kind of shy away from the word normal. I prefer the word typical because who is normal? I mean, what's normal? I'm not normal. I'm sure of it. I don't know anyone who really is. Normal is very subjective. So the word typical really is more accurate because that's describing sort of the norm in terms of like the generally accepted behaviors out there. So what we see most often is typical. So just a word on that because this is a space of absolutely no judgment, and in my field, everybody that comes to me is somebody that's in pain, and we're working to get them feeling better. And there's no judgment. Nobody is struggling with a mental illness because they chose that. No little child woke up one day and said, "I really want to be chronically depressed. I want to think about suicide all the time." I mean, nobody ever wanted that. Nobody woke up one day thinking, "I would love to be hooked on a substance that I cannot get off of." No one ever chose that. So we deal with them in kindness and compassion. A person is not defined by their diagnosis. And that's actually in your program, you'll see a quote by Brittany Moses that says, "Your struggle is not your identity." Same thing. I love that was in the program. All right, next slide, please. The DSM-5 is sort of the diagnostic manual, sort of the Bible of mental health. So diagnostic statistical manual, there have been 5 iterations, so that's where the 5 comes from. So this is where we as clinicians get our definitions and our diagnostic criteria for the various mental health conditions. So looking at depression, there's a quick little mnemonic, SIGI caps. It doesn't really make sense, but that's kind of a mnemonic, and you see it up on the slide. That gives us some criteria to look at when we're talking about if somebody is dealing with depression. There are lots of specific pieces of information. We look at how long somebody's been dealing with that, how severe, how many days of the week they deal with it. But these are the main symptoms we're looking at when we're talking about depression. So sleep disturbances, either hypersomnia, where you sleep constantly, you just can't get enough, you crave it, or you can't fall asleep or stay asleep. And for a lot of people I see, their sleep's very flipped, and so they are very sleepy through the day, just very drowsy, take long naps, but then at night when they go to lie down, even though their body's tired, their brain is just like popping, and they are just thinking all the thoughts. They can't fall asleep, or their sleep's disrupted, and they're waking up a lot. The I is interest is diminished in things you normally enjoy. The clinical term for that is anhedonia, so a lack of pleasure. You normally enjoy getting together with family, or you normally enjoy Christmas, and this year there's no joy to it. You're just kind of going through the motions. Energy loss, fatigue, just lethargy, sluggishness. The C is concentration is disrupted, and many times I see people who come to me saying, "I think I have ADHD. I can't focus, I can't concentrate." We have to really dig a little deeper on that, because that could be, as we explore their symptoms, we start to realize maybe they're dealing with some depression, especially if it's coming on as an adult. It's not something they struggled with when they were 12 or younger. So concentration is disrupted, can't focus, easily distracted. Appetite can go one of 2 ways. It can plunge, and people can go with no appetite whatsoever. Kind of goes back to that anhedonia idea, like I used to enjoy eating, I used to enjoy this food, and now I just don't have any interest in it. Or their stomach is in knots and they just cannot eat, no appetite whatsoever, so people can drop weight pretty dramatically. On the other hand, there are a lot of people who stress eat and who eat because that's the one comfort they have, and everything else might be a dumpster fire, but they've got food. And so people tend to gain weight. So it can be one of either ways. Psychomotor activity changes. So that means like your patterns of movement. So for some people with depression, they're moving very slowly. Everything is just like, it's painful. And there is literal pain, physical pain associated with depression. We're discovering that more and more. So movement can be slow, the fatigue can kind of drag you down, or people might move very rapidly and agitatedly, just kind of zipping from thing to thing. So changes in movement. And then, of course, suicidal thoughts or actions. We're going to explore this more a little later on, but if somebody's thinking about it, or maybe, having kind of just those vague thoughts of, the people in my life would be better off if I wasn't here, what difference do I make, those kinds of thoughts. Next slide. All right. We're going to talk about the anxiety as defined by DSM-5. Some of these symptoms are outlined. Again, this is not exhaustive. This is just kind of looking at some of the features that we're assessing if you were to go to a professional with these issues. This is what we would be looking for. Excessive worrying or apprehension about work, school, relationships, really anything going on in your life, that the worrying occurs more days than not, and that has to occur for at least 6 months. So it's not just a short burst of suddenly realizing something's unraveling in your life and, oh my word, what am I going to do? This is a pattern that's established at least over 6 months or more. The worrying is nearly impossible to control. So no matter how many times your partner, your husband, your family member, your coworker tells you, oh, stop worrying about it. Just stop. Just go take a walk. You're fine. Stop worrying. You worry all the time. It doesn't help. You can't just shut it off. So it's nearly impossible to control. Symptoms of anxiety can include restlessness, fatigue, disrupted concentration, just like we talked about with the depression. So again, people coming in and saying, I think I have ADHD, we really have to kind of pull apart some of the other symptoms to see if there might just really be an intense kind of baseline anxiety happening that's distracting them. Sometimes spacing out and just like your mind just goes blank and you just can't think of anything. That can happen with anxiety. Irritability, for sure. This is a big one, and this is one that women especially just beat themselves up about. Like, I'm just so irritable. Like, every little thing just gets under my skin. I don't understand. I'm not that person. Why am I feeling this way? A lot of times that's rooted in anxiety or fear of loss of control. Muscle tension. I don't know if y'all notice yourselves doing this, but I will find that if I'm dealing with anxiety, my shoulders are coming up and up and up and up and up, and I will just have this terrible like tension in my shoulders and across the back of my neck. And that's true for a lot of people. Like, you carry your anxiety in your body. There's a lot of science behind this. There's evidence that that is true. We carry our depression, we carry our anxiety in our bodies and deal with sometimes pretty excruciating pain as a result. So muscle tension, just feeling like you just cannot relax. Sleep disturbances, big time. That's the falling asleep. The brain just doesn't shut off. That's the waking up suddenly with a startle and panicking for no apparent reason. So the anxiety, part of the diagnostic criteria, it's causing distress or impaired function at home, at work, at school, in social settings. You find yourself withdrawing because it's just too much to people that day. Like, I just do not have it in me to go to this thing and talk to a bunch of people. It's overwhelming. You start to withdraw from friendships, from social gatherings, even at work. Your interactions become very limited with your coworkers, or you're just not able to do your job very effectively because your mind is so distracted with those anxious thoughts. So it can create a negative impact, and that's part of the criteria. Once it gets to the point where it's really starting to impact these areas, that's when people should think about maybe getting some help, maybe talking to somebody about that. And we also have to rule out, and this is really true with depression, most mental health conditions, we want to rule out that it's not caused by the use of a substance of any kind, or alcohol is a substance, any sort of drugs, medications can cause heightened anxiety, can cause depression. We have to look at all of the possible causes, because there could be some underlying things that are driving the anxiety, driving depression as well. So thyroid conditions can really amp up anxiety big time. Vitamin D deficiency in particular can cause a lot of fatigue. So we just want to talk about, if you come to somebody and get help, they'll ask you a lot of questions about your medical condition, any lab work that's ever been out of whack, things like that. We want to rule out that it's not being driven by something underneath. Next slide. I just want to touch on these terms because these are growing in awareness and growing in sort of like the social consciousness. There's a lot of discussion around neurotypical versus neurodivergent. I just wanted to define these terms. There's a little bit of debate about whether some of these conditions we're talking about today truly fall under the category of neurodivergent, but that's a term that's defined by differing in mental or neurological function from what is considered typical. So it's a pretty broad term, pretty broad definition. We see it in use a lot in reference to people with autism spectrum disorder, and that has also really grown in awareness, which is great for people who suffer with that condition. There's a lot more openness and discussion around it. So neurodivergent is just a term that you'll hear a lot on the news. There are a lot of companies that are seeking intentionally to hire people that are neurodivergent because of the great variety that they bring to the table. They're very creative in many ways. A lot of times people that struggle with some of these conditions actually have some really wonderful qualities that they bring, that they add value. So you'll hear the term neurodivergent, and then neurotypical, of course, is somebody who is not, does not display those characteristics of neurodivergence. So just wanted to touch on that because, again, these are terms that we're seeing more and more often. All right, go ahead and switch. I will try not to get on my soapbox here. Self-diagnosis is one of the more frustrating things that we deal with in my field. People that take quizzes on Facebook or TikTok, and I call it the TikTok syndrome just because most often people, especially within a certain age demographic, will come to me and they'll be like, I was on TikTok and I took this quiz and I am sure I have fill in the blank. So, self-awareness is great. Like, I am not opposed to information. I'm putting information out here today to kind of help guide whether or not people, want to seek help. But I just want to preface that nothing that I'm giving you today, that there are quizzes, questionnaires, things like that are used in a clinical setting, and we'll look at those in the second half of the presentation. None of that is designed to formulate a diagnosis. So nobody leave here today thinking that I'm going to walk out with a diagnosis. Absolutely not. These are tools that will help you identify whether you need to seek help, maybe talk to somebody and then, share your symptoms with them, and then together you kind of work on whether you have a diagnosis. But anyway, I just wanted to touch on the whole self-diagnosis thing because, again, I'm not opposed to people doing research. That's what Googles are for. We research our symptoms. And depending on what you're looking at, you could leave a Google search with all sorts of horrible diseases, and terrible conditions. But there are some pitfalls to self-diagnosis. And so I call it TikTok syndrome just because there's just a growing number of people on TikTok just sharing their story. That's great, but also sharing things that are really like guiding people down the road of, oh, I think I have such and such. And then they come to me. So, reasons why we can't rely on the information that we're getting from some of these quizzes and some of these social media sources. We have blind spots. And when we're doing the quiz ourselves, we may not be really taking in all the information. We see ourselves a certain way. And one of the pitfalls in general of dealing with a mental health illness or disorder is that we don't see the whole picture necessarily. And so that's where counseling really comes into place, or having a loving friend or family member that we can talk to, that provides a mirror to sort of reflect back to us, so we can see things that we might not have otherwise seen. So we have blind spots, and so these quizzes don't always account for that, because we're self-reporting. There's a potential to misapply the diagnostic criteria, and so some conditions mimic others. For instance, ADHD looks very much like bipolar depression or bipolar disorder, the manic side of bipolar disorder. So that's just an example. There are a lot of conditions that kind of mimic each other, and so if you don't have the background to know how to distinguish, we can kind of misdiagnose ourselves, or walk around thinking, oh my goodness, I have bipolar disorder, or something else, when in reality that's not it at all. That can lead to creating a false narrative about ourselves, and especially I see this within a certain age demographic. Especially, there are a lot of people who self-diagnose, and then they go out and tell everybody around them, oh, I have such and such, I'm such and such. And there might be some reasons for that, perhaps, that they get something from that, but it's not always accurate. And that's kind of the turning it into the identity. There are people who really want to have some sort of identity, and so they've even sought that in having a diagnosis. So we want to watch out for that. Finally, not everything is a diagnosis. We have quirks, and I think there can be a tendency to try to overdiagnose. And I have one little thing that I just like to do all the time. Well, no, I don't have OCD. I just really like to do this thing. Or there's one particular thing that really stresses me out, or something that I really focus on a lot. You may not have any other symptoms of a diagnosis, but there's just a thing or two, or just things you do. So I think I've seen a tendency for people to want to diagnose everything. So, because there is some growing awareness, which again, I like the fact there's growing awareness about mental health conditions, but the downside of that is that there tends to be almost this push to microanalyze ourselves, and then once we notice certain trends in ourselves, think, oh, we got to go get that diagnosed. No, it might just be a quirk. You might just have a quirk. So that's my little soapbox on the TikTok syndrome there. Thanks for indulging me. Next slide. Okay, so what does medicine do? This is the science-y stuff, and I'll try not to dwell on this too long, but this is the stuff that I kind of geek out about. I think it's really cool. There's a lot of theory in this. Some of this we have data, we have evidence that this is all, that these are the chemicals associated with mood and neurological function, but there is some theory in this as well, which is partly why the meds and the treatments that we have for these conditions are great, but there's still a lot of room for improvement. So neurotransmitters, these are the little chemical messengers that carry signals between nerve cells. So these are the little bundles, the little information-filled molecules that transmit information back and forth. So the main neurotransmitters that we seek to manipulate with medication are serotonin, GABA, norepinephrine, and dopamine. And there are some others, and it's actually quite complex, but these are the main ones that we're manipulating with the medications, which I'll go into here in future slides. So serotonin, most of us are familiar with that term. That's getting to be more known when we talk about serotonin. It actually regulates a lot of body functions. So breathing, digestion, healing, sleep, and mood. So it's actually a very important chemical in the body, and there are receptors throughout your body, not just in the brain. So it's particularly associated with mood features like happiness and satisfaction, which goes back to, when you're depressed and you're not happy and you're not satisfied, you're experiencing that loss of pleasure, that inability to enjoy things. We theorize that your serotonin levels are low, you're not manufacturing enough serotonin, or the serotonin is not capable of landing on the receptors in the brain long enough to do what it needs to do before it gets sucked back into the system and recycled. GABA, that's a shortened term for a real long chemical name that I can't pronounce, so I'm just going to call it GABA. It's inhibitory chemical that reduces neuron activity or excitability, and it pumps the brakes on the central nervous system. So that's kind of your like, whoa, slow down, calm down chemical. And when those receptors are not activated or we don't have enough GABA in our system, our anxiety runs wild, runs amok. So we need GABA in our lives, in our brains. We need that to kind of help pump the brakes, give us that pause. Remember, logically things are okay. You're not in danger. Calm down. So GABA is the calm down chemical. Norepinephrine is part of the fight or flight system. So it's like adrenaline. It generally provides energy and motivation, which is lacking or very low in depression. So norepinephrine is our energy chemical. And so some of the medications we use specifically target norepinephrine. And then dopamine, that's the pleasure chemical, and that we hear a lot about, people really seeking dopamine, which unfortunately you can get a dopamine hit through some wholesome, wonderful ways, but also through some not so healthy ways. So dopamine can be found in anything that we find pleasure in. So people get a dopamine hit from being adventurous and skydiving or bungee jumping, things like that. They also can get it through substances. They can get it through a great conversation with their spouse. They can get it in so many different ways. So dopamine is the pleasure chemical, and it's not even as much the pleasure of doing something fun as it is the anticipation of doing something great. So it's the feeling when you're about to head into a really great meal, or you're about to go on this really fun vacation. So dopamine is super, super important and often lacking for people, especially with depression. All right, just a quick word on this. This is where this stuff gets a little dry, a little bit kind of boring. I'll try not to linger too long on these slides, but I do want to touch on the categories of medications, because in my realm, that's what I do. I prescribe, so I'm familiar with these meds, the categories of them, and I've seen them really be game changers for a lot of people. I'll just say meds aren't the whole answer, not by any means. And we'll talk about that more in the second half of the presentation. There are a lot of other strategies at play. So if you look at your mental health care as sort of a pie, medications are a wedge of that pie. They are not the whole thing. So I am the first person. I put people on meds all day long, every day. That's what I do. I do not think medicine is the answer for everybody. And I have seen meds do wonderful things. I've seen meds do not so wonderful things. So that's my preface to the discussion on med classes, is that there are a lot of categories. They're very helpful, and a lot of wonderful things with these. Tricyclic antidepressants, the anafranil, amitriptyline, a lot of us are familiar with those from back years and years ago. Those came out, the MAOIs, those came out back in the 50s, and that was kind of the first medication that came on the scene to treat depression. And then in the 80s, the selective serotonin reuptake inhibitors came out, those SSRIs. So finally, in 1987, a miracle drug, which I'm telling you, I've seen it do some wonderful things. Prozac came out in 1987, and that changed the game as far as treating depression. So the SSRIs are typically the first line of treatment. So they train us in school when you're putting somebody on medication for anxiety or depression, and I'm going to say both because both are treated by these meds. Both anxiety and depression are treated by these SSRIs. This is the first go-to. So you're going to select something from this category because it's targeting that serotonin. And as we know, the serotonin is associated with mood features, particularly happiness and satisfaction. It does have some benefits in other areas. So these act by enhancing serotonin levels. The reuptake inhibition just means that a lot of these neurotransmitters function on a loop, and they're at absolutely incredible speeds. They are being circulated through the brain. So they land on the receptor, and then it's sucked back up into the system, and then it lands for a moment, and then it's re-uptaken into the system and reused over and over. So that's where this medicine comes in. It inhibits the reuptake, allowing those serotonin molecules to sit on the receptors for a longer period of time, so we actually get some benefit from them. So these act wherever there are serotonin receptors. So the brain, densely populated with serotonin receptors. Guess where else is populated densely with serotonin receptors? The gut. So the stomach and the intestine, all the yards and yards and yards of intestine, those are very heavily populated with serotonin receptors. And that explains a very important connection we can talk about a little later, the brain-gut connection. So gut health affects brain function very significantly. It also explains why some people may develop some GI side effects when they first start these meds, and some of you may know from experience, some of these medications can cause a whole host of GI upsets ranging top to bottom, when you first take them, because they're landing on all the serotonin receptors you have. So these are considered safe. I've used these a good bit. Some of them, not all of them, are appropriate for pregnancy. So even pregnant ladies can take some of these safely. Even children, some of them are appropriate for children to take. So they're generally considered safe, but they just range a good bit in how they work. Some of them are a little more sedating than others. So there are some specific differences between some of these. So there are some examples. They're listed: Prozac, Zoloft, Paxil, Lexapro, Celexa, and Luvox. Those are some SSRIs. All right, our next slide is going to go into the cousin category, and that's the serotonin norepinephrine reuptake inhibitors. Norepinephrine, like we mentioned earlier, that's the energy chemical, that's kind of your adrenaline, and so this category of medicine came out in the 90s. Effexor was the first one, and that was even more of a game changer, because not only is that targeting your mood, but it's giving you some energy. So that motivation piece and that psychomotor slowing, where you're just like, everything is just so hard, I'm just struggling to walk, struggling to move. All of that kind of started turning around with this category of medicine. So the norepinephrine and serotonin really brought a lot more to the game. So these are helpful for improving energy and focus and reducing brain fog. Y'all know what I mean when I talk about brain fog? It's just that medicine head feeling almost, where it's just it just takes so much effort to focus, and it's forgetting words, and it's walking into a room like, oh, what am I in here for? Oh, what did I do? What just happened? So it's kind of that foggy, sort of detached feeling that you have that can come with depression or anxiety. So this med category helps cut through that really well with that norepinephrine. It gives that little spice, that little ooh, all right, cool. The lights are on. I can see what I'm looking for. It can be a little bit overstimulating, so it's one of the things that I look at when I'm dealing with somebody that might have a really, really severe anxiety and also depression. A lot of times those are hand in hand. I don't see too many people that have one and not the other, so they're very linked. So we always are a little cautious with this category, because that norepinephrine spice can be a bit much for somebody that's dealing with severe, very fragile anxiety. But even people with severe anxiety can do beautifully with these. It's ultimately, at the end of the day, it's how your brain chemistry responds. So these are great. This category, the SNRIs, are really, really great for people who deal with nerve pain, arthritis pain, and fibromyalgia. There are growing numbers of people who are diagnosed with fibromyalgia, which is still a bit of a mystery condition, and it's a big bucket of symptoms, and it covers everything from pain, severe pain, crippling pain for some people, mood symptoms, irritability, depression, anxiety. It can cover terrible brain fog, just memory impact and concentration impact, things like that. So fibromyalgia is growing on our radar of millions and millions of people dealing with it. What are we going to do about it? One of the first line treatments for fibromyalgia is a med from this category, because this does a great job. And I've had people with pretty bad arthritis pain that started taking a med in this category. And once we kind of stepped the dose up where it was therapeutic, they noticed that they felt tremendous relief, like such relief from their joint pain. So I'm really happy that this category of meds offers some pain relief as well. This is a category, and you'll see the list of meds at the bottom that are associated with this category. So Cymbalta, Effexor, Savella, Pristiq, those are all really good meds, particularly for women. These provide a lot of benefit in the area of somatic stabilization. So if you're kind of walking through that perimenopausal, postmenopausal journey and you're noticing like problems regulating temperature, you're noticing nights, like hot flashes, night sweats, mood shifts, things like that, this is a really good category to help women stabilize those symptoms. So we really like this category for women. All right, the next category is the norepinephrine and dopamine reuptake inhibitors. There aren't many of these. It's a pretty limited category, and there's probably more stuff coming out. There's a lot of combination medicine coming out new, but for our purposes today, looking at what this category can do. So this category treats depression without kind of triggering or stimulating serotonin. It's not really acting on serotonin. So that makes this medicine very beneficial for people who have experienced side effects from serotonergic meds, really bad GI issues, or people with bipolar disorder who cannot safely take serotonin medicine. And that's kind of a whole other discussion, but some of these medications can actually make certain types of depression much worse. So people with bipolar disorder aren't always able to take these safely. And there are certain other conditions as well. We have to be careful with these meds, of course. But anyway, the norepinephrine dopamine reuptake inhibitors are working on those neurotransmitters. And what they're doing is providing energy, motivation, focus, carving through that brain fog, and doing so in a way that doesn't make you feel that lethargy that some of the other serotonin-based meds can cause. So there's Wellbutrin, which has been around a long time, and there's Aplenzin, which is just a newer form of Wellbutrin that's a little pricier. But these are meds that are commonly used that are from this category, and these are almost like mini stimulants. They're not nearly as potent as the Adderall and Ritalin and some of those, but they work on similar brain chemistry. They're kind of helping target executive function in the frontal lobe, where you're, processing decision making, you're prioritizing tasks, kind of figuring out what you're going to do first, things that require you to sort and prioritize and make critical thinkings, critical judgments about things, decision making. Those are all skills that the frontal lobe deals with, those executive function skills. And this category of medicine that's a little more stimulating really works on that part of the brain and helping sharpen those skills. So this is a great medication category, and these are meds you would most definitely take in the morning because they will keep you up. In most cases, they will keep you up through the night if you take them late. So we don't really use these for anxiety. It's not contraindicated for somebody that has anxiety. A lot of people with anxiety do fine with this. But we're cautious. If someone comes to us with depression and anxiety and they have a really sensitive anxiety, this can be very stimulating, so we have to ease in very carefully. Whereas some of the other medications can cause weight gain, this category of medicine actually can cause weight loss. And some people use the medicine in this category to help them achieve their fitness goals, their weight goals if they're overweight. This is helpful because it suppresses appetite. But even that comes with risks and warnings, and we assess you carefully for any like eating disorders, things that we're not trying to enable or make that symptom worse. But this can be a helpful med for somebody that's seeking to lose weight. They just need a little extra help with the appetite, kind of calming some of the desire to binge eat or overeat, snack chronically, things like that. This medicine can cause weight loss. So we're also cautious with this in kids. We're cautious in this with people that are already underweight. So there are pros and cons to everything, I guess, but this can also lean on the sleep, cause you to be more irritable. So there are risks associated, which are listed there. Benzos. That is a term that some people may be familiar with. We're hearing more and more about it. Benzos, benzodiazepines. These medications act directly on the GABA receptors. So the GABA was the pump the brakes, the take a minute, catch your breath. Those are that helpful chemical in the brain. So benzodiazepines are anti-anxiety, anxiolytic medications that land on the GABA receptors and help enhance that pump the brake, slow down that fight or flight, very calming, very soothing, and they're meant to be used kind of in moments of pretty intense anxiety. So these are wonderful for people with panic disorder, who are prone to panic attacks, especially if you've worked with it a while, you know how to time it, so you kind of catch the panic attack when you're about level 5 or 6 versus when you're level 10, then you're chasing it. These meds can be really helpful in those moments. There are definitely some risks with these. We know about the opioid crisis. We've all been hearing about that for several years now. There's a terrible crisis in our country with opioid use, and people now laced products on the streets that people are sadly dying from all the time. And as tragic as that is, there's been a Xanax crisis for years that hasn't been talked about as much as the opioids. In fact, not nearly to the extent of the opioid crisis, but the Xanax crisis is huge and has been very, very detrimental. And for many people, they may have a friend or a family member that has gotten kind of pulled into the Xanax cycle. And it can be pretty scary. So there's a lot of risk with this category. As with most meds, and your provider, if you were to go to a provider and talk about medications, they would lay these out for you so that you make an informed decision about whatever med it is that they're thinking might be a good fit. So benzos can be extremely helpful. They can actually, give you your life back. If you are prone to panic attacks all the time or severe anxiety, these can give you calm, to the extent that you can get out and do your job and function. But we just have to be mindful that, somebody who may have struggled with a substance use disorder in the past or is currently dealing with a substance use disorder, we wouldn't want to enable that issue or, make that issue worse by giving them something that could potentially pull them further into addiction. Benzos that are commonly used, Xanax, Ativan, Valium, Klonopin, these are all in the same category. They vary based on how long they stay in your system. So the delivery curve for Xanax, for instance, it works within 15 minutes. It's in your system for like an hour or two. So it works very quickly for a panic attack, but when it wears off, it's gone. And then there can be some rebound anxiety and just, all of it kind of comes rushing back. So Xanax, very, very short acting. And then you kind of move across the spectrum to the very long-acting Valium, clorazepate, Tranxene, some of those really, really long-acting that are more helpful for like once a day, maybe twice a day, kind of keeping a level in your system. So the delivery curve is a lot flatter and longer. So it's going to take those, more like 45 minutes to start working, but they'll stay in your system for a nice long time. And then when they fade off, it's usually a gentle fade versus I'm calm and now I am level 10, all the anxiety is right back. So they vary in their length and kind of the way they act, but they all target those GABA receptors. So there's value and use for each of these meds. One of the risks, I kind of camped on that addiction risk for a minute, but some of the other risks with these meds, in particular, what I see a lot of is memory impairment over a length of time, which varies depending on how your body tolerates the medicine. You can start to develop memory loss, starts with short term, can also cause difficulty in forming new memories. So retaining information and being able to recall information that you're learning currently later on can be impacted by these meds. So it's just something that you're kind of mindful of. If you are taking this medicine, great. Just make sure that you're taking it as prescribed, and then just watch. If your memory starts to suffer, that'll be something you want to bring up to your provider. So memory impairment can happen. Some of these meds can cause depression because they're dialing down. So they're kind of calming the system, pumping the brakes really well, but they might kind of overdo it and cause your mood to kind of tank along with your anxiety. So the two are kind of both going down. So if you were to take this medicine, you might notice that you're starting to feel more depressed. Pay attention to that and let your provider know. Drowsiness. Definitely, these can make you sleepy. You want to be cautious when you're driving. You be very, very careful. You can get a DUI for driving under the influence of a Benadryl. I have a patient who took Benadryl to kind of help calm them, and they drove under the influence of Benadryl and got a DUI. So anything that can impair your cognition is going to impair your ability to make decisions. You don't want to go sign for a loan. You don't want to make any big important decisions under the influence of any medicine that could impair your judgment. So those are some risks with those. But overall, just really what a wonderful category of medicine for those who need it. All right. Second generation antipsychotics. I struggle with the name of this category because these are such wonderful medications for people with treatment-resistant depression. And I often will use a low dose of one of these medications, perhaps in addition to somebody's SSRI, if they're just not quite getting the relief they need. There's a lot of evidence behind this, a lot of data, a lot of research. It doesn't mean that you are psychotic. And again, that we are not our diagnosis, but I hear that a lot when I go to prescribe a medication, because the first thing someone does, most informed people, I do it. If you get prescribed a med, you're going to get on the Googles. All right, what is this? What is this doing? So we are, a little nervous about the term antipsychotic. No, doesn't mean you're psychotic. Low dose of these meds are phenomenal for targeting depressive symptoms, and it has nothing to do with psychosis. But at the higher end of the dose range, these are wonderful meds for people with paranoia, with delusions, with other symptoms that are more along the lines of schizophrenia, severe mania, things like that. So this category is pretty broad, and these are multitaskers, so they can target depending on the dose. Some of these are wonderful for insomnia, and that's all we use them for. It's just really stubborn insomnia, like Seroquel is great for sleep for some people. You move up the range a little bit, and it targets depression in a really great way. And then at the top of the range, again, is where you're targeting more of your delusional, paranoid, things like that. So these can cause metabolic side effects for sure. And anybody with much experience in taking some of these medications may have noticed that some of the older ones in particular can cause some issues with weight, elevation in blood glucose, elevation in cholesterol. So these are meds that we really want to monitor labs periodically, maybe every 6 months, depending on what your numbers look like, just to make sure we're not doing anything in the background metabolically that's going to cause you any problems. But these can be fantastic medications. They're great for sleep. They're great for people who have that low appetite and are just dropping weight because their depression is so bad. This has turned things around for people in that area tremendously. It enhances appetite, gets you back to a healthy weight, gets that nutrition back where it needs to be so that you're able to benefit from all the vitamins and minerals and things in the food that you need. So those listed there, Abilify, Seroquel, Zyprexa. Some of the newer ones, Rexulti, Vraylar, unbelievably good for some people. So just, again, it's about knowing the risks and benefits of these. All right. There are some things in general to know. I spoke earlier about the mental health care pie and the things that we do to treat our mental health. Medicine is not the whole pie. Medicine is a wedge in that pie. So here are some things to keep in mind about medicine. Medicines can reduce mood and anxiety symptoms, improve your energy and focus, enable engagement with coping skills. These are great for somebody that wants to go into counseling. They understand, yeah, that would really be good for me. I am so anxious, or I am so depressed, I can't even right now. Like, down the road maybe I can go to a counselor, but right now I feel so bad. I am dealing with these symptoms so severely that I can't engage it. Like, I'm not focused enough to really sit and listen to how to learn how to breathe and do the coping skills, journal and things like that. And so I really partner with counselors in that, like, yes, I will help kind of lower some of the severity. The medicine will. I won't. The medicine that I prescribe will help lower the severity of the symptoms to enable you to engage those skills and be able to sit in a session and really gather information from the session and engage with your counselor. So this really, the idea is that this enhances your counseling experience and gets you the most for your money, the most out of those sessions. These meds can also enhance your sleep, enhance your nutrition, enhance your functions of daily living. In some cases, the medicine makes such a dramatic impact, you actually are able to go back to work. You're able to go to your kids' dance recital. You're able to do things you literally couldn't do before. And medication can affect your resilience. So it gives you a little bit more margin, a little bit more of that rubber band stretch that you need sometimes to deal with things that are really difficult or uncomfortable. So medicine will help enhance your ability to tolerate hard things. Medicine can't, and you all know this, I know you're wonderfully intelligent women, and so you don't need me to go through this in great depth, but I want to mention what meds cannot do, because I think people come sometimes to their prescriber asking for medicine to help them with things. They're dealing with symptoms, but those symptoms might be created by a really toxic home environment or relationship or a really horrible job that's just sucking away their life force. So medicine can't change those circumstances. You are still going to be in that house. You're still going to be working with those people. You're still going to have that boss. You're still going to have that partner that's, maybe unkind or mistreating you. So the medicine isn't going to help those things. Another thing, and I really want to drive this home, medicine does not replace coping skills. Medicine is not a substitute for therapy. And while therapy and counseling, kind of interchangeable, while those things are not for everyone, there are a lot of people that say, I don't feel comfortable. I just can't go in and sit down and talk to a stranger, even a professional stranger, about my stuff. It's not for 100% of everybody. But for so many people, there's evidence, like they've done research that shows that there's benefit to counseling. And so medicine will enable you to engage with your counselor. It does not replace counseling, because the vast majority of treatment for a lot of these cycles of depression and anxiety has to do with changing our thought patterns and getting our kind of rewiring our brains to think in different ways and view things from a different lens. And that's where counseling is so powerful. So medicine will not replace coping skills or counseling. Medicine often doesn't treat personality disorders. And I'm not going to camp on that very long, because this isn't really, there's just not time to go into discussion about all the personality disorders, but there are many personality disorders, and those are treated very effectively in most cases with counseling and skill building emotional tolerance, things like that. It's a really difficult category of diagnosis, but it's an important one to address and treat. Medicine doesn't generally help that. Unfortunately, we haven't yet developed a medication that will correct some of those issues that people struggle with personality disorders. And it's not really going to cure much. It's palliative. It's going to treat symptoms. Medicine isn't necessarily going to cure something. And so, we want to make sure people know that, so that they're not looking to this to do something that's going to create long-term fix. It'll treat symptoms. Medicine should never, please remember this. This is important. Sorry, I keep tapping my lapel of mic. Sorry. Medicine should never change your personality. And this is part of my spiel when I first begin medicating somebody. If you aren't you anymore when you take this, we got to change this now. This is something I tell people to reach out to me in between appointments. Don't suffer with this. If your loved ones are coming and telling you, you're just not you anymore, I don't know, who even are you? And I don't mean like this is me without depression, like I'm brighter, I'm happier, but still you. Like you can remember back to a time when you weren't depressed or you weren't super anxious, and so this is the you of that time. I mean like a core difference. That should never happen. So it's not the right med for you if that's happening. Preventing you from feeling your feelings. If you numb out, I don't want to numb you out. And that you have to feel to heal is true. And for people with anxiety and especially for trauma, oh my word. If you numb out, you won't heal. It won't ever get down to the level of processing that you need. So I don't want to numb you out. I don't want the medicine to numb you out. You need to feel appropriate emotion. You need to feel sadness. You need to be able to cry when something sad happens. You need to feel sympathy and empathy. You need to laugh and have fun and be silly and think something's hilarious. You need to be joyful when something good happens and not just be in that numb zone of, oh, great. Oh, tomorrow's Christmas. Neat. Like we don't want you numb. This is particularly important for my female patients, but it's not really gender specific. It's for anybody, but I feel like women tend to be in a little bit more of a vulnerable position, particularly in relationships. I do not want the medicine to ever make you complicit. You're in a bad situation, you're feeling depressed because you're in a relationship that's abusive or a job situation that's abusive. You go to your provider to get medication to help deal with the terrible feelings that it gives you to be in that situation. The anger, the sadness, the depression, the feelings of worthlessness and low self-esteem. You go to get treatment for that. You get started on an SSRI, SNRI, something like that. We're not trying to make it so that you put up with that situation better. I don't ever want the medicine to make it so you come into my office one day and I see the difference in you. You're just kind of like limp and, yeah, I'm feeling better. Well, what's going on at home? Still the same stuff? Yeah, but it's okay. I hear that a lot. And then it's time to talk about something different because you need to care and you need to be in a position where you can advocate for yourself. So if the medicine numbs you out and takes you into that sort of like spaced out realm where you're just like, it just doesn't bother me as much now, then that's not what we're looking for. So we don't want to make it easier for a bad situation to continue to victimize you. Medication risks. I've covered some of them along the way. I'm going to look at these in a little more depth. Suicidal or homicidal ideation, it is what it sounds like. The medication can sometimes give you the energy that you may need to follow through on the plan. And that's dark and it's frightening. But medicine, if you hear about medicine causing suicidality, it's because somebody may have had a really specific plan for how they were going to follow through and end their lives, and they just needed a little extra boost to get it done. So it's rare, but you have to be mindful that if for any reason medication starts to motivate you toward that, or you may have never had a suicidal thought or a homicidal thought of harming someone else. You may have never had a thought like that in your life. I've had a few cases where people have come to me and said, oh my word, I was driving on the highway about a week after I started this med, and I was just thinking, I could just turn the wheel right here and just go right off the side and just be done. I could just crash right into this tree. So anything like that ever happens, I tell people constantly, stop it. Don't touch that medicine again. Get help. Get with your people. Call your friend. If you need to call a crisis line, and we'll talk about that in a minute, do it because the medicine should in no way ever cause that. Other risks include weight changes, and we kind of talked about that earlier. Sexual side effects, actual physical performance for men and women, as well as desire for sexual activity. Those can be pretty profoundly impacted, and that's a game changer for a lot of people. If it's ruining your sexual connection with your spouse, that's an important part of your marriage relationship, and that's not something that we want to take away from your marriage. So if that's happening, that's something, it's awkward to talk about, but people have this conversation with me daily, so I'm pretty used to it. That's something you need to bring up to your prescriber and let them know because, we don't want the medicine harming the relationship in that area. Insomnia or drowsiness, it can go either way. We talked about the GI stuff that first week or two on a new medication that targets serotonin can be a little rough. hang in there. If it's not too severe, try to hang in there, because after about 2 weeks max, it'll settle and your body will acclimate and you won't have to be in the bathroom every 5 minutes. Irritability, for sure, if it makes you just like Hulk rage, anything that, just really changes your personality, makes you very sensitive and irritable, that's a side effect you need to talk about. Make you more anxious, make you forgetful. It can trigger manic symptoms or mania, and that, those listed there: impulsivity, recklessness, personality changes. There's a lot under that umbrella that I won't delve into too deeply, but some of the medications can pull out a bipolar disorder diagnosis that we may not have realized somebody had, because it's so subtle and it varies so much. Metabolic changes, we kind of talked about, glucose, cholesterol, weight, as well as changes in seizure threshold. There are certain medications like Wellbutrin that you really shouldn't take if you've ever had a seizure, and so your provider is going to ask you a lot about your medical history and if you've had any seizures. Some of these meds can dramatically alter your seizure threshold, make it easier for you to have a seizure. And then the emotional flattening we talked about. All right, important stuff for your prescriber to know. Got to help us help you. We don't judge you. If you go to a mental health provider and you're talking about this stuff, if you feel judged, it's not a good fit. And you need to find someone where you feel heard, you feel seen, and you're not judged. You are there because you're hurting or you're suffering in some way. We're here to help. And I can tell you, you can't shock me. Whatever your story is, it's very difficult to shock somebody that works in this field. So be honest, be transparent, be very open about your struggles, about what you've dealt with. We're here to help. We don't judge you. You're not a bad person because you're struggling with these things. My goodness. The lies depression tells us, just tells us that we're all these horrible things and blames us, makes it our fault. No. Those are distortions, those are lies. So please be 100% honest about any suicidal thoughts or homicidal thoughts you may be having or have had, any thoughts of self-harm or actions of self-harm, cutting, burning, biting. I know some people that will scrape their knuckles across brick, even just things that aren't going to injure them to the point of hospitalization, but things that are hurting them. We need to know that. Be open about your usage of alcohol, your usage of recreational substances, how much Benadryl you take, how much NyQuil you drink at night. I just drink it straight from the bottle. We need to know that. It's not to judge. It's not because we're going to sit and lecture you for 20 minutes on why you need to cut back your alcohol and, oh my gosh, what are you, a drunk? No. We just need to know so we kind of have an idea of what is competing for those brain receptors, because we're about to add medicine that could really be very dangerous if it's mixed with alcohol or mixed with recreational substances, mixed with mom's Xanax that she doesn't know I take, or the Ativan that my brother gives me from his when I need it. We just need to know about that stuff. Medical history, we're going to be asking you a lot of questions about what your underlying medical stuff is, what meds do you take. Just be real transparent about that. And also, we can see it. Most of our electronic health records give us access to pharmacy refill histories, and we're not snooping, but I pull it up right there with the patient sitting with me, and I'll say, okay, I see you're on some cholesterol medicine, you're on a blood pressure med, you might be on this or that. So it's just, we want to ask you in case the refill history for some reason doesn't populate the full way, or there might be a med that was given as a sample. Not everything shows up on that refill history. The pharmacy may not enter it in at the moment, and so there might be some things missing. So we're going to ask you about your underlying medical stuff, what meds you've taken, what meds you currently take. Any past mental health related hospitalizations, whether it's a trip to the ER because you really thought you were having a heart attack and it was panic, or long-term mental health facility inpatient stays. We want to know about that, when they were, how long they were, what did you do afterwards. Intensive outpatient, if you were kind of doing a day program where you went to therapy sessions and did med management, but then got to come home and sleep in your bed and kind of go back and forth. All that stuff we need to know. Be detailed about your symptoms. The better you can describe how you're feeling, the better I can help you. So think about how you're feeling. There are even emotion wheels. If you Google an emotion wheel, awesome tool. awesome tool. A lot of people use that successfully to really identify how they're feeling, because, I get the shoulder shrug, and sometimes the brain fog makes it so difficult to communicate that you really can't be detailed about what you're feeling. But the better detail you can offer, or say, it's like, I had a wonderful, heartbreaking but wonderful description. One lady came in with really bad depression, and she told me, I feel like I'm in the bottom of a well. The well goes down about 12, 15 feet into the ground, and it's this narrow shaft, and it's just big enough for my body to fit in. And I feel the walls all around me, and it's so dark down there, I can't see my hand in front of my face. There's no light, there's no help, there's no voice, there's no sound. It's just dark, and it's all around me, and I feel it so close. And I just kind of sat for a minute and thought about what she was describing, and just my heart ached for her, like, what misery, what misery. And she still worked, she still took care of her family the best she could. I mean, it was the best she could do. And she knew that she couldn't give it the full effort and the full capacity because of how bad she felt. But again, going back to what we talked about in the beginning, there might be somebody sitting next to you. There might be somebody checking out your groceries at the store. There might be somebody that you interact with in the public that's in that well. And it's dark, and it's cold, and it's lonely. And they are the only human in the world. They're the last human in the world, and this is just torture in their perspective. This is how their life feels to them. So let's be kind. Let's be gracious. Let's understand that some people are just dealing with such terrible pain. So all of that to say, please be descriptive. And that description told me, wow, okay, we got to dig in here. We're going to be aggressive. We're going to meet more frequently, because this could easily tip into a suicidal situation if you're feeling that hopeless. So be descriptive. Share your concerns, fears, or questions about treatment. Let me know. Let the provider know what concerns you have. Ask questions. We don't want you to not know about risks. We don't want to keep you in the dark. And, I'm not saying that you literally shouldn't look at information about medicine, or that you don't need to do any research on your symptoms. It's good to be prepared and to have questions. Write them down. I love it when people pull out a list. I have some questions for you, and they'll pull out a paper. Like, yes, let's go. Like, ask me your questions. I want to know what fears you have, and try to relieve those as best we can. And the commitment from the provider is that they will also be transparent with you. And to the best of our ability, we'll make sure we tell you all the risks you need to watch for, all the side effects you need, so you can make a decision on that. So share your concerns and fears or questions. Be open about how the medicine makes you feel. You're not going to hurt their feelings if it feels like trash. If it feels horrible, if you take something for a couple of weeks and you're like, oh, this is terrible, I feel worse. I have some really, really gentle and polite patients that come to me and they're like, it's fine. Like, obviously it's not fine. It's okay. I only had diarrhea 12 times yesterday. Like, oh my goodness, that's horrible. Why didn't you tell me? This is stuff to tell me like 2 weeks in. So be open and honest and transparent about how the medicine is making you feel. I didn't make the medicine, okay, we're gonna cross that off the list. That's gonna be on the allergy list. That's gonna be, we're not even gonna look at that again. So you're not hurting anyone's feelings. So don't feel any pressure like if I admit that this made me feel worse, they're gonna just give up on me or they're gonna be hurt. No. We're not looking for you to make us feel good. We're here to help you feel better. We don't need you to come in to the appointment and, oh no, everything's great. I can't help you if you're not transparent about how you're feeling. So please be open about how the medicine is working. Another thing I didn't put on the slides, didn't quite fit. Be aware that many of these meds take minimal 4 to 6 weeks. Minimal. That means for the first 4 weeks, you're going to take a Tic Tac. I mean, it's going to feel like it's not doing anything in some cases. Keep taking it, please. Please keep taking it unless it's making you feel worse. And if it's making you feel worse in any way, contact the provider and just let them know, like, hey, is this normal? Is this typical? Should I be feeling nauseous this far out? Should I be having these really vivid dreams that are keeping me up at night? Be transparent about that. But if the medicine you're taking just doesn't feel like anything and you've been taking it for a good 4 weeks, stay the course. Your provider may tell you keep on, because at about week 6, the lights are going to start coming on. About week 8, you're going to really notice some improvements. So most medicine, with the exception of some benzos, stimulants, a few meds work much quicker, but in general, medications are going to need time to start working. Some other things to help you, help us help you, and really honestly to kind of help you help yourself, really is the better term for this slide. Don't leave your meds in your car. A lot of people feel like, well, I'll remember it better. I'm going to take it right when I start work, so I'll just keep it in my car so I have access to it. Really not a good idea. Car theft often is thieves that break into cars are looking for pills, so you really don't want to keep your meds in your car. Also, with the heat, which down here is almost year-round, even if the temperature outside isn't bad, the heat in the car is enough to alter the chemistry of the medicine, so you don't want to keep your pills in your car because you could end up with a different product than what you picked up from the pharmacy. So I've had people's cars ransacked because thieves saw a pharmacy bag, they picked up their medicine and they just like tossed it on the floor in the bag, and then they ran in to do another errand, they came back, their window was smashed, their full brand new bottle of medicine was taken. It's just so frustrating. And again, alteration, I've had people literally just have a terrible med side effect. I'm laughing because I'm thinking of a vivid description of one. Medicine can work very differently if it's been sitting in the heat of the car. You don't want to get like high off your antidepressant because it sat in the car and mutated. Don't take the medicine any differently than prescribed. Can't really emphasize that enough. If it's anything that causes you to feel calm or sedated, so, well, this feels pretty nice, I'm going to take a couple of these. I really need that sleep. Or a couple of these stimulant medications because I really need to study for that test, and this one's just not going to keep me up all night. I gotta pound this in. I got to get this done. I'm going to take 2. Don't take your medicine any differently than the way it's prescribed. Even if you and your provider have discussed that in the future you'll probably go up on the dose, don't make that decision yourself. Please, please contact your prescriber. I can't emphasize how important this is, and the way that this could make a really good medicine turn really, really bad for somebody. Don't leave your meds where anyone can get to them. House guests, kids, pets, these need to be kept in a safe place. I'm not suggesting that everybody that comes to your house is looking for pills, but you just don't know what someone's struggle might be. So the old medicine cabinet in the bathroom may be fine, but you want to remember that it also might be unsafe to do that. So don't lose your meds. Keep them away from drains and sinks. I've had a lot of patients, especially with controlled meds like sleep aids, like Ambien or Restoril or Lunesta, or their Xanax or their Ativan that just mysteriously fell down the drain. I don't know what it is about drains, but I get this quite a bit from people where they lost their medicine or it accidentally fell down the drain, and it does happen. I mean, we tend to keep meds near sinks because it's bathroom or it's kitchen, and the pill bottle, can be open, and if you knock it, it dumps it and it ends up landing in the toilet or the sink. That can happen, but just be aware that if it's a controlled substance like a benzodiazepine, a prescription sleep aid, a stimulant like Adderall or Ritalin, Vyvanse, one of those, if you lose it, we can't really help. There are very few circumstances under which we can refill early. So just be aware, keep really, really close watch over those meds, and don't run out early because you're likely not to be able to get a refill until it's due again. And then never take anyone else's prescribed medicine. We kind of all know that, but really refrain from taking somebody else's medicine, and don't give anyone else yours. You don't know what your med could do to somebody else, particularly like stimulants. You don't know if that person has a heart condition. It's just never a good idea. You don't want to be a dealer. You don't want to deal meds to somebody else. So really avoid doing that, and then it'll make you run short. Final segment of this session before we break. This is helping you help others. Don't be afraid to ask the hard questions. Suicide rates are rising. We're kind of aware of that. The CDC tracks this data, and reports from 2020 report that over 45,000 people died by suicide. where 1.2 million adults, that's just adults, attempted suicide. So the rates are growing among young teens, and actually the highest rates are among men ages 65 and older. So be aware of that. Check on your people, check on your friends, check on your family. Don't assume that everyone's okay. If you haven't seen or heard from somebody in a while, just send them a text. Hey, thinking of you. You okay? Anything going on? Watch for things like isolation, bundling up, especially in hot weather, if people might be trying to hide scars or fresh wounds from self-harm, unexplained cuts, comments and posts about feeling hopeless or worthless, selling or giving away personal things, commenting things like, I'd be better off dead, or my family would be better off if I were dead, or wishing they were dead, things like that. Watch those things. Monitor your children's communications and devices. I can't preach on this enough. Giving your child unbridled access to the internet and social media is extremely risky. There is a program called Bark. If you go to bark.us, there's a website. I'm not promoting the product. I haven't used it myself, so I'm just saying this is one of the options out there. I'm not here to endorse any products, but I'm just saying this is a system, and there are others like this, where it's a parental control tool, and it monitors texts, emails, social media engagements, YouTube, all of those things for potential safety concerns. So it watches for phrasing that indicates things like suicidality and a number of different phrases, ways that could be. So you want to really pay attention, know what your kids are saying, monitor their devices, especially if you bought the device, it's yours. You know, you have the right to access that. And we've always told our kids when they were old enough to have their own cell phone, you know, we purchased this. This belongs to us. You use it. We have the right to spot check your communications at any point. So really be aware that a lot of that stuff is buried in those communications. You also want to let your kids know to kind of watch out. And it doesn't mean you scare them. We don't sit and have long discussions all the time about something this dark and heavy, but you do want to let your kids know, hey, if your friends ever talk about wanting to end their lives, or they talk about cutting, or they talk about, killing somebody else, or bringing a gun to school, or, if your friends or people at school are saying things that sound suicidal or homicidal, tell a responsible adult. Don't go tell your other friend. Go straight to a teacher, straight to the guidance counselor, principal. Tell your parent. Your parent can pick that up. I had a situation like that, my daughter, last year, in a thread of communications with a classmate over an assignment. Actually, this classmate started sharing some things about self-harm and suicidality, and I was able to bring that to the school administration, who followed through on that. So tell your kids to be on the lookout, and to tell a responsible adult so they can get help for that student or that friend that needs it. Don't be afraid to ask the hard questions. The best way to address this, if you do have a friend that's struggling, or you suspect they might be struggling, is to ask them straight up, do you feel like you want to end your life? Do you feel like today you might end your life? Don't beat around the bush. You're not going to plant the idea in their head if you ask them these questions. You're not giving them the idea like, oh, well, maybe I will. No, they've already thought about it. That's already on the front of their brain. Don't be afraid to ask that question. Stay with them if you can, or get them with somebody that you trust. Don't leave them alone. You can call 911, take them to the emergency room if you feel like they're in imminent danger, if they have a very specific plan. You want to remove access, particularly if it's your child or somebody that lives in the house with you and you have the ability to remove their access to sharps, to firearms, chemicals, drugs, anything that they could use. Just staying with them is really going to be the best thing if you can, or make sure that they're with somebody. There is a suicide rating scale. Columbia University developed this tool. It's a simple tool. It's been validated. It's very sound. And this tool is used in a lot of settings to assess for suicidality. We actually have copies of this tool. We also have copies of a resource card with crisis numbers on it that we'll make available to all of you today. And that is going to give you some tools if you are interacting with somebody that you feel, or if you yourself are interacting or are feeling in any way like you might end your life, or with somebody that could. You just never know. Again, we don't know. And some of the people that I've known over time that seemed the happiest, that were the brightest at the party, that were the most outgoing, that was their last goodbye. And we didn't know. You don't know what someone's pain, what someone's struggle might be. So having these tools like the crisis line cards and this suicide screening tool is going to be helpful. And I did include a copy of that. You can't see it from there. This tool is what there's a copy of for everybody here. The bottom portion, you don't kind of disregard that. This was a tool, they modified this for a facility, and this was their action plan. So, don't be confused by all that lingo down at the bottom of the tool. But the risk categories, the yellow, the orange, the red, those just kind of give you an idea of how severe is this. It's not your responsibility to utilize this tool. Really what I included this for was to see what questions are valuable. What are some things you can ask somebody? You don't have to score it. You don't have to pull this out and rate it or anything like that. But this just gives you some familiarity with kind of questions that I ask people if we're talking about suicidality. These are the things we're looking at. Some final things about this issue, and this is, again, a very dark, heavy issue, but I don't want to be remiss and ignore this topic in a seminar about mental health matters. This is life and death, literally. Christians can be suicidal too. Please do not ever think for a moment that because someone loves Jesus, they've given their lives to him, that they don't also think about ending their life, sometimes chronically. You can be a Christian and still struggle with feeling suicidal. You can be so overwhelmed by your depression, by your anxiety, that it literally drives you to the point where you just can't live another day. You feel. Christians can experience this too. And if I can't drive home any other points, I want to make sure you realize that Christians struggle with depression. Christians struggle with anxiety, crippling anxiety. This is not an indicator of you're not a strong enough Christian. This is not an indicator of, just pray more. The church, Big C Church, has been guilty for years of minimalizing these symptoms and explaining, well, you just don't have enough faith. Pray it away. That depression is just the devil trying to get you down. Nope. No, these are clinical conditions, and you are no worse of a Christian for being depressed and having clinical, depression, anxiety than if you had diabetes. It's not something that is a reflection of your walk with Christ. So Christians can be suicidal too. Christian friends and family members, we need to check on them, just the same as any others. Avoid referring to suicide as being selfish or the easy way out. That's language that we kind of talked about at the beginning, the person-first language. It's important not to refer to these things as being selfish. Oh, well, so-and-so just did this selfish thing. They just took the easy way out and ended their life. No. A lot of people end their lives because they felt like they were a burden to others. They were actually doing it because they felt like living was selfish. And so in their distorted sort of like depressed thinking, they thought they were doing the least selfish thing by removing themselves from the picture so that their family didn't have to deal with, quote unquote, their issues anymore, because they see the impact that it has to live with someone who is chronically depressed or anxious. So don't refer to it as the easy way out. Don't refer to it as being selfish. There is absolutely nothing easy about feeling suicidal. There's hope. There is hope. The biggest protection, they've done some studies on this, the biggest protection against suicide is meaningful social connection. It's like what we're doing here, getting together with friends, being part of a church, being part of a small group, being part of a book club, being part of a gym, maintaining friendships, maintaining contact with your family. That is a very powerful protection from suicide. more so even than medicine. Just having those connections, having eyes on you. The more you isolate and withdraw, the more in danger you are. Suicidality is contagious. It's actually one of the more contagious mortality illnesses. According to CDC, people are much, much more likely to follow through on a suicide if they have a first-degree relative or friend that's done so.